Hi, everyone. Welcome to the very first episode of Stop, Collaborate, and Listen with myself, Danielle, and Leslie. We're co-founders of Coping Creative and our collaborating partner and friend, Dion, of the Nurse Dion Show on YouTube. Being that this is our first episode and we literally have no idea what we are doing, so take it easy on us, folks. Although Dion would definitely say something similar to, we're doing something.
We are doing something.
We figured we would focus this first episode on just introducing ourselves to you all and chatting through what our hopes and dreams for the podcast are. Before we really get into all of that, though, for those of you that can see us, you may be asking yourself, why do we all look so cool? Well, if you didn't already know, we all happen to share a common love for 90s hip-hop and R&B. So to bring a little bit of flair to this first episode and really lighten the mood, we decided to have a genuine throwback to the 90s. But don't expect it every episode. It's just for fun today. We maybe if we get crazy, we might add in some extra themes along the way, but don't expect it.
Danielle, I don't think we just look cool. I think we are.
We are cool.
That's facts. Straight facts. Wait, do I have to start?
No.
Yeah, you start.
I can start.
Yeah.
So, I am Dion. I go by Nurse Dion on social platforms. I have 10 years of experience. Actually, I was just thinking, I think I'm like in the 11 to 12 year mark, but after 10 years, I think I just stopped counting. I am. I feel it. I feel it. Working bedside, the 6 years that led into it, of the start of my career, I worked as a CNA. And when I came back, after leaving the industry for about 3 years, I came back and I was like, no, I got to finish my nursing degree. So I spent the last since 2020, I started my career in the peak of COVID, literally March, first week of March. I remember sitting at the table during my preceptorship with Jenny, and we were like, what is this COVID thing? And having to wear a mask.
Mm-hmm.
So I've been nurse now since 2020.
That was in Tampa?
I was in Tampa, Florida.
Okay,
Yeah.
You were in Tampa for that.
Yeah,
I wasn't sure if you had gone to California yet or not.
Yeah, no.
Because it was in COVID when you went over there to California, right?
No. So I would visit California during that time, but it was during 2022 when I actually moved out to Los Angeles.
Yeah. It was a way of life at that point.
Yeah. Been enjoying the Cali life and then working on this project now, which I'm so honored to have you two join me on that, the Nurse Dion channel, where the goal is to help reduce fear associated with coming to the hospital as well as going to the doctor's office as much as we can. Because let's face it, going to the hospital is a scary place, whether you're an adult and sometimes, well, even more so for kids, should I say.
So how long have you been a child life specialist, Danielle?
I have been a child life specialist since 2007. My schooling and my undergrad is in child development, and I did all my schooling out in Michigan. Graduated from Central Michigan University, fire up chips, and moved very quickly after graduation to Phoenix. Started a one-person child life program out there in a community hospital that saw pediatrics in the emergency department and an inpatient. And then was out there for like 8 years, I think. 8 years. Moved to Tampa and have been here since then. And also started a one-person child life program at a community hospital that is now, I think, considered the third busiest pediatric emergency department in the area.
Wow.
So
you're kind of a big deal, is what you're saying.
That with that situation and then like without that situation still a big deal. But yeah. Mm-hmm. We've kind of grown that program a little bit and things have developed, and that's kind of how I met Leslie. So we go back because she's at a sister facility of the same hospital network that we both work through, and we found a common denominator of 90s hip hop and R&B. Go figure.
Love that.
And
Biggie
then we
or Tupac?
Yes, I'm a Tupac girl. She's a Biggie girl. We coexist. But so that's kind of how we met, and then the dream of bringing our skill set out into the community and being able to provide for more families evolved. It had evolved.
That it was.
Leslie still has the napkin that we wrote our logo on.
I do.
Aw.
I am very proud of that.
Mhm.
Yeah. Very, very much a visionary in that aspect. So,
Well, and you
Well-
pretty much drew it. So,
Yeah.
I mean,
and then we digitized it, and it's perfect and lovely.
What about your background, Leslie?
So I've been a child life specialist for 15 years. I was introduced to child life by a speech therapist friend of mine. And I just kind of researched what a child life specialist was, did all the typical things we do, getting into the field, volunteering. I was living in Kansas at the time, going to college, didn't really know what I wanted to do upon graduating.
wait, how
Moved-
did you end up in Kansas, though? Like, how did you get to Kansas? You just said, I might want to go to school in Kansas?
No, love.
Ah, that'll
Love.
do
I did not know.
Yeah.
that, honestly.
it. Love will do that.
Yeah.
Good old love.
Yeah. So went out there to finish school and then moved back to Florida after I graduated. And I applied for a practicum at a hospital and also did my internship there. And then after my internship, I applied for a couple positions there, didn't get it. So I think I got hired on like 9 months after my internship at that same hospital. And so I spent the first 10 years of my career there on a med surg unit is where I met Dion,
Whoop, whoop.
was a patient care tech at the time. And then I transferred to a smaller community hospital, sister hospital of that larger system, and have been there for 5 years. So that's how Danielle and I met. Dion and I had a amazing professional relationship, and we've just all unified with a larger dream.
Yeah, I mean, I don't think either one of you would say this, but I feel like that speaks where Dion is at now with what he is doing and his own goals and his own passion for making things easier for kids in the hospital and in general. I think that speaks volume to you, Leslie, and your skill set and the things that you brought to that environment that you exposed Dion to. Because without that, he would probably still have the same passions and still be very, into making a difference and all those things. But I think it would just look differently. And I
Mhm.
think that is just amazing, and that you guys have continued to stay close and, have a business relationship and a professional working relationship. So, I just think that's amazing, and I think that you, Dion, have just continued to like flourish and like just take the little bits that you might have gained from her and just like continue to run with it and continue to like make it a bigger thing every time, which I just think is so cool.
Mhm.
Oh, well, thank you. No, it's been an honor, like I said, to work alongside of you guys to create this dream and this vision. Which is why I also love the idea of this podcast and what solutions it can provide. What do you think the mission is for this podcast? So, what's our purpose for doing this? You think
Education.
education,
In a lot of
Awareness.
different ways.
Yeah.
awareness to help maybe advocate a lot of
Yep.
times for family members.
Yeah, and even
caregivers.
just giving insights into the hospital world and empowering, families and not just parents, but other caregivers, medical professionals. I think awareness for our profession too, like beyond the hospital walls, like, our community isn't familiar with child life services, and that was a big reason why we went into private practice too, because there's such a gap in our services in the community. So I think awareness on a lot of different aspects, and certainly our profession.
Yeah, I think I used to always say, like, well, when I would explain my role to people, whether that was in the hospital or outside of it, I would always kind of say, like, they'd be like, oh, I never heard of that. That's so cool. And I would be like, yeah, you don't hear about it unless you've had
Mhm.
a kiddo that's been in the hospital and
Sure.
has experienced it, or you've heard it from somebody else who had a kiddo in the hospital. And I think that, like you said, we've noticed this gap in like services of like we can only do so much, when we're at the bedside, but
Sure.
like there's so much of what we do that is like
transferable.
preventative. You know
Yeah,
what I
yeah.
mean? Like it's preventative. It's like we're prepping these kids ahead of time. We're giving them the opportunity to, cope with certain situations, but we can be doing that even further ahead of time or helping them cope with other situations in daily life because it is transferable to, not just within the hospital setting, but also like other life stressors and other things that may be going on in their life that we can help them cope with. And like I think all three of us are really in it for like building resiliency within
Absolutely.
these kids, like so that when life happens, and it will, how do they cope? Like what is their strategy? Like
Mm-hmm.
if we give them those resources, they will be able to do those things. And it's at the bedside, it's outside of the bedside, it's helping get the word out through podcasts and education and awareness that way. And I just truly, truly believe that like we can make a difference and that we will make a difference and we are
We
making
are
a
making a
difference.
We are making.
difference. Yeah.
We're doing something.
We're doing something.
Danielle, you just touched on something that I just want to rewind to and just, shine light on. As child life specialists, like you said, you are giving parents as well as children tools and resources to help cope while they're in the hospital, but you are also giving them tools to help outside of the hospital.
Right.
Because while the hospital is a stressful place, usually often associated with trauma environment, as soon as they go out of those doors, the world is a crazy place. The world, there's so much trauma in the world already as it is. So the tools that they do learn in the hospital when they're bedside going through these procedures can also help them
Absolutely.
in the real world. So I find that beautiful.
Or even just their next doctor's visit.
Well, that's what
Yeah.
I was
The
going to
next
say.
dentist
Yeah,
visit.
there's
So
so
many
many
things. Yeah.
kids that don't ever interface with the hospital setting.
Sure.
So it's, dental visits, doctor's visits, and, there's just a reach there beyond, the hospital.
I think too, when we're at the bedside and we are teaching and giving resources and like showing and giving the words that are needed to like empower even just like caregivers and parents and things like that, they don't know what their role is in that situation. They are very unfamiliar. They're already stressed. They're already kind of like at a peak for like, being overstimulated and then trying to also take care of a kiddo who's either sick or injured or whatever. So when we kind of give them that power back and we say, this is your role, this is what you should be doing, whatever. And then they take that with them when they leave too, not just the kids. And then when they go to their next visit or their kid is having, some big feelings down the line, they have kind of some of those tips and tricks that we went through with them in those moments of stress within the hospital, and they use them in the real world.
I think too, with like exposure to things in the hospital setting that can be used outside, like pain management stuff, a lot of parents, family members don't know what's available to them very easily. So I'll say, ask your doctor if they'll write a script for EMLA, like numbing cream, or you can buy Buzzy on Amazon, or, just little tricks, or even just bringing a bag of ice and just putting it on your kid's skin while they wait for their immunizations, just little things like that that they don't even know are available to them. So
honestly, even just
do
like
it all.
allowing them to pick a Band-Aid
Mhm.
before they go, just creating some choice for them
choice.
is like it.
It's so
for a
simple.
3-year-old, it is like life changing.
It's so simple, and
they are just excited to put that Band-Aid on. They don't care how it gets there. Sometimes, not always the case. Sometimes they are very not willing to participate in anything that's happening prior to the Band-Aid placement.
Sure.
But
yeah, all of these things are very simple and easy things that people just don't know about. It's funny because Danielle and I'm always like, I just told the family to like have their kid pick out a Band-Aid or whatever it is, and they were like blown away by that. I was like, am I like being punked or something? That was the simplest thing. So it really is so simple. It's just we have that insight and that knowledge and that skill set to be able to share that with the families that we're working with to empower them, and that there's a trickle effect to that. So
and I think life is just so busy these days.
Mhm.
Like it's just there's so many things happening that just stopping to take that second to think about things a little bit different, or like what is the best option or what is the best choice for this kiddo or whatever it may be. Like sometimes it's just that there's not enough room in people's brains to like come up with the simple solution or to like think about things outside the box a little bit more. So that's where, like the three of us kind of come in to say like, hey, well, why don't we try it this way? Or why don't we try it that way? And if it doesn't work, then we know it doesn't work, but we tried it and we'll try something else. So that I think the adaptability for understanding that every kid is different. Every kid's going to have different needs. Every kid's going to have a different coping style. Every family dynamic is going to be different, and we really take kind of like all of that into consideration when we make, coping plans, or when you're getting ready to, do your own little child life prep, Dion, for, your patient when your child life specialist maybe is in another room,
Sure.
because we're generally getting pulled all
Pulled all
over the
over.
place,
Because we train you.
Absolutely.
I always say that. I say my job is to make all of my nurses their own little child life specialists in the event that I am not available. Call me first, but
You're not replaceable.
correct.
If we are in the building, call us. But
We
if
may be
we-
in another
right.
situation,
you
procedure.
tap into those skills. Yeah.
So you tapped into something that I actually had a question that I feel like we would have an interesting answer for. But how do nurses and child life work together to ensure a child receives a tailored care to their developmental stage?
So I'll go first, I suppose, because I have thoughts on that.
Good.
I think there's a lot of different ways.
Mhm.
I think that my approach is generally, say, nurse calls and says, hey, I have this kiddo that needs XYZ. So I say, okay, my first thing that I'm going to do is ask the nurse questions. How were they when you did the vitals? How were they when they in the room? What is happening that you have observed? Because I want to know what your thoughts are on the situation first, because I want your perspective, because that's also going to help me tailor this as a collaborative approach, because I need to know where your head is at first, and then I can kind of like gain my own assessment, because I get information from the nurse and the staff, and then I can go in. Then I'm going to do my own assessment, kind of ask questions about, medical procedures from the past, because a lot of times nurses don't think about that. Providers don't think about that. They may see something in the chart, but sometimes they don't see that in the chart. So when I find out that, and also sometimes it's not in the chart, because if I find out, oh, this kid had labs 3 weeks ago, a lab draw at the outpatient lab center, that's not in their chart. So no wonder this kid is refusing to get on the bed and is having a hard time and is just having some big emotions about what's going on. So then I can take all of that information that I have gained. Mama, how did that go? What was that like? What seemed to work? What didn't work? And I can take that back to the nurse and say, hey, you know why that kid is really struggling? What my guess is probably because they had an outpatient lab draw 3 weeks ago. And so we're going to have to take it a little bit slow. And then we kind of just develop a plan together. I give my suggestions. I ask sometimes, like, are you good with X, Y, and Z to the nurse? So that way I have their, their involvement and their collaboration and their cooperation. And we're just all really in it for the same goal, which is to make things as easy as possible for kids in the hospital.
Absolutely.
Like that truly is. And like in return, that makes it easier for everybody else. And moving forward, it makes it easier for those people that they're going to interact with, because they're going to go from maybe having like a not positive experience to now having a positive experience, to hopefully carrying that on as a positive. And some kids will have negative, and that's fine. That's okay. It doesn't necessarily mean that they're not coping. It just means that maybe we're not using the right approach, or maybe we need a little bit more time or buy-in from, the staff, or whatever it may be. Even sometimes parents, like sometimes parents are just like, you know what, we had to hold them down and this is what happened, and oh, it's going to be a disaster. And then we kind of go in and we take our time, we get down on their level. The nurse is very, like on board with just kind of listening to what's going on and taking that approach. And I just think that then parents are like blown away, because we've done magic at that point, because this kid was able to do what they thought they weren't going to be able to do. And to be fair, sometimes I think that. I'm like, oh, this is not going to be a great situation. And then they surprise me even. And I think that's kind of like just the headspace of sometimes everybody in the room.
And I think it takes time to get to that point with, the nurses or, whoever it is that you're working with, like I'm huge on building those relationships and building that trust and that mutual respect. Education is huge.
Mm-hmm.
So any way you can filter just your role, because there's a lot of, new nurses in the field and who have never been exposed to child life. So just really taking that time to build those professional relationships, but also personal relationships with them too.
In both of
kind
my
of
hospitals, I really like worked on personal relationships with the nursing staff and the provider staff
love that.
first.
I was the
Because I was
opposite.
like, you gotta like me before you're gonna listen to what I have to say. You have to be able to like trust that I, like you said, trust like that I kind of know what I'm doing. But it's easier for me personally to get buy-in for people who are like, oh, you're cool.
You're a cool person.
Yeah, exactly.
Yeah.
Like okay, let's do this. Let's work together. Like, and so even though I think sometimes people think that's probably not my approach, it very much is.
You touched
Mine
on
was opposite. Yeah. When I started, and I've loosened up a lot, but I was just very professional and I just wanted to keep my professional and personal life like separate. So I never really connected with them personally of like, oh, like how's your family or that kind of thing, or wouldn't hang out with anybody outside of work, or I just kind of stayed in my bubble. But I really did focus on those professional relationships and that education, like going to staff meetings and just, you know, letting everybody know like what services we provide and just kind of getting in that way. So I was definitely the opposite.
So did you find it that as soon as you opened up and started actually focusing in on the personal relationships, that your role was a little bit more accepted from, for example, nursing staff?
I think it took me a while to get there. So I feel like my buy-in with everybody was just visibility, consistency, but my approach is very much like, hey, like what do you like, very collaborative and like, in the early days, like as you gain like seniority and like confidence and like your skill set, you can kind of navigate those situations a little bit more assertively.
Sure.
But in the beginning, I was more coming from a approach of, hey, well, what do you think about this? Like, what if we tried this? Like, would you be comfortable maybe trying a comfort position or having them sit with mom? So it was
That's a
kind
great
of
place to
more,
do that.
yeah, and right, and that works, too. So I think it's interesting because we do have different approaches because you have different personality types, like, with the nurses that you're working with. So you kind of learn their personalities and what you can kind of get away with and push a little bit more with one versus, okay, like I may only be able to get away with like advocating for one thing. So what's the most important thing here for this child? So I think really getting to know your staff and spending that time to build those relationships, like that trust and respect, and the buy-in, like really does develop over that time.
I
You
love
got to be
that.
consistent. Yeah, for sure.
I love that. Danielle, you touched on something that I actually want to rewind to, especially with new nurses and maybe even veteran nurses. Is there ever a wrong time to consult child life?
So
Yes.
this is yeah. So I don't know where I heard this from. I do not want to take credit for it, but I once heard we are in the business of preventing fires. It is very difficult for us to put out a fire. So if that makes sense, once the fire has started and there is already chaos and there is already stress and there is already anxiety, yes, we can step in those moments if the space allows us to do that and sometimes de-escalate. But sometimes it is too far gone. This kid is too stressed. The longer we wait, the more information they get, the more we try to de-escalate, the more they are actually continuing to escalate. So
Fight or flight.
really is, yeah, it just really depends on the situation, but there is, I don't want to say a wrong time because I don't like that verbiage, but like there are situations where
We can be more successful
in
than
different
others.
ways.
Yeah.
Yeah, like it just depends really. I don't know how to like verbalize that, but like really kind of just depends on the situation. So I don't
Sure.
know if there's a wrong time, but there is like a too late situation. I
Well,
don't know.
preparation is ideal for every situation. Is
Everything that we
it
do
right? And it's, backed by research that preparing kids fear the unknown. So really giving them developmentally appropriate language and tools and, education on what's going to happen, like it really eliminates that, not eliminates, but it reduces that anxiety. So a big part of what we do is preparing kids and preventing these, minimizing that stress and trauma. So it is ideal to get us involved before a procedure is happening, although that is not always realistic. And especially depending on the setting. Like sometimes in the ER, like we're doing things now because it's an emergent situation and we can still, it's getting us involved, still, and we can prepare those kids like as it's happening. So,
which is still different than once a situation has spiraled out of control. Like then you are just prolonging medical treatment, medical care. You're also, just adding like that fuel to the fire of like now there's a new person in here and now we have to still build quick rapport before those kids trust us. And so it's just there's just a lot of components that can make the situation a little bit more chaotic and more intense. And so that's why I say, when I say, if given the space to do so. So like if there's a situation where a kid is like kind of next level, really kind of freaking out, just really big emotions, just not, wanting to cooperate or anything like that. And the nurse says, hey, this kid really needs some child life. And they all leave the room and give me the space and the time to reconcile what has kind of already occurred and really kind of do some recovery, then that's not necessarily a wrong time. But if you're expecting me to go in there while everybody's already holding this kid down and they're screaming and they're just asking me to bring the tablet, like that's not, no.
I think
Right.
you're saying something too that a lot of nurses probably are. Their argument is, well, we're fixed on time. We have to get this procedure done because not only they have to go into the OR, for example, we're prepping them from OR, but I have another patient that I have to tend to. But what you're saying, it sounds like, is you guys, we as nurses especially, should consult child life specialists pretty much as soon as we can.
Yep.
The sooner the better. That gives everybody ample enough time to do their assessment. We have our assessment, you have your assessment, and like you guys said already, we can come together, collaborate on coming up with a tailored approach for the kids.
Oh, sorry. I mean, think of it like this. If you have a kid in respiratory distress, you are going to call respiratory.
Sure.
Okay. So if you have a kid in emotional distress, like you
Correct.
call child life. So it's like any other resource that you
Right.
have available to you, So
But nurses need to
you
understand,
do have the time.
or not just nurses, I don't want to say that. Providers, everyone
Yeah.
across the board needs to understand emotional distress can happen as soon as they touch down in the hospital. If they have any
Before they even
experience.
get in the car,
Get in the car.
yeah.
It's like a dog. The dog.
I'm fine. I'm okay. I feel fine.
Yeah,
Like, don't
no.
take me. Like, because they've had those
They've had this
experiences.
experience.
But I will say that nurses and providers, some of them will say they have kind of learned over time and they will go, hey, this kid's probably going to get a line. There's no orders. The provider hasn't even seen that.
Yep.
But based on the nursing assessment, you kind of already know. And you're like, ugh, like I've already been in there. They're very apprehensive. They're very guarded. Like, so I know that this kid has been vomiting and they've tried to whatever it was, you're going to call us. And some people do that. And that is really the best approach. It's like, if you know that they are most likely going to have some sort of like need for a procedure or prep of some sort, like you know, and the providers will do that too, like, hey, just so you know, they're probably gonna have to start a line on this kid, like I haven't been in there yet, but just based on the story, like, so we know, and and that's the collaboration piece, right?
And that's the thing, like, it's, as a nurse, it's like I'm trying to figure out how to make my job a little easier. So, Leslie, this kid's gonna get admitted dehydrated. We already know we're gonna have to start a line. Do you have a moment to just quickly go in there and assess them? And because we already know, Dr. So-and-so is going to be putting orders for this IV. And honestly, I don't have the fight in me right now. So if we can actually give the kid the tools, the coping strategies, the prep while we're waiting for orders,
Mm-hmm.
that's the ideal situation to be in. I mean, I understand a lot of times we're fighting for time, but that is time that could have been given to the child that you guys could have stepped in and boom, did your thing, and everyone's happy at the end of the day. At least less, traumatized, less fearful, hopefully.
That's why I feel
Better
like
coping.
education is so important with our staff because they don't know what they don't know. So sometimes they don't know what we can provide or what we're there for, and it takes time to really help people understand that. So I think, a lot of times I'll say, hey, let me know, like, if this kid is getting an IV, like, I can help support, prepare them ahead of time and support during the procedure. So I'll be very specific about what it is that I can do for their patient. So I think that education piece, and again, building those relationships is huge. And I do like to give people the benefit of the doubt. That's just my personality too. And like, we all get busy, and we're all human, and we forget. And there can be this feeling of, like, from child life specialists of, oh, they didn't call me, or they forgot to call me. And sometimes, it isn't there's not a personal reason behind that. So I think understanding and putting yourself in their shoes too, and giving people grace. And we're not self-reliant on consults. Like, we self-consult, and we're very visible on the units and in tune with what's happening, so that in those moments, maybe, or depending on the nurse, like, we're advocating for ourselves and our services for that patient too. So it's very, there's a lot of variables to that dynamic.
I was going to say that you mentioned. I think that when you say, like, that we're giving them grace because they didn't call us, like, I think that there's something to that too, from the perspective of, like, sometimes they will go in there and think, like, oh, this kid's going to do great. And then they, are busy. So they just kind of go in and do it. And they didn't have the thought to call us in that moment, because they're like, oh, this is an older kid. They're probably going to do okay, whatever it may be. And then, they'll come out, the situation was not great. And they're like, really could have used you today, Leslie. Like, where were you? And those are the nurses that you do kind of put a little bit of trust into too, that, like, okay, like, you recognize that probably could have gone differently, and I think that giving that grace and showing that grace over time, they do kind of start to, like, come back to us. You know what I mean? Like, they kind of start to understand more about what a difference, we make for those kids and families.
And I mean, there are those staff members that are just resistant, like, to our services too. So that's a little bit more of a challenge, like, where we're going to have to assert ourselves, like, in our services.
Well, maybe you can speak to, like, the the theory that nurses are territorial. You know what I mean? Like, I've heard that based on certain units. I have heard that just based in the fact that it's pediatrics, and so they're littles, or like NICU, because they're tiny babies, and so they get very, like, this is my patient, I want to take the best care of them. And I understand that perspective, but maybe you can kind of speak to that.
That's interesting. I personally, I've never had that mentality. I understand sometimes there's a sense of control we want with our patients because of control situations. It's as simple as that. However, my approach has never been territorial in any means.
Have you seen that?
Honestly, I've maybe seen it more with other nurses. Like,
that's what I mean.
Like,
I'm not specifically
child.
but,
yeah. Well, I'm saying, like, with other providers trying to provide care. For example, a child life specialist coming in and wanting to do their services while this patient is doing so and so, and a nurse stepping in and saying, "No, you can't do that right now," and things like that. I've never seen that, but I've seen, literally, like I said, nurses will say, "Hey, do you need help to do XYZ?" They're like, "Wait, no, I got it. Don't do it." I've seen that happen.
Yeah.
But yeah, no, that's an interesting concept.
Yeah. I think that's kind of what I mean by that. Like, not necessarily territorial against, like, child life specialists, but just in general. They don't really want the other nurses to go in. They like the control of their patient. They're going to do all the things.
So,
and I will say that maybe that's, like, more of, like, a generational
could be, yeah.
Or a tenured thing.
Like the nurses who have been around for a long time. And maybe that was kind of like what the industry, was like back then.
Sure.
Maybe healthcare was more one person, I do my patients, you do yours. And I think that, again, you
Well,
can probably speak more to like
we
the collaboration piece just in terms of the medical team.
yeah, but going back to that, we all have a unique approach to care. We all have different personalities and
So many variables.
so many variables. So whereas I believe I have a certain personality trait that I will bring to a table or to bring to a patient's room, whereas so and so may not have that same personality, but I know they're really good at this. So I might reach out to them to do this particular thing, but nothing else because it's like, your approach is slightly different than mine, and I'm already going down this path with them. I don't want to.
Yeah.
You got to
bring in
know your
that-
people.
Yeah.
You
Know
got to know your people.
exactly, and there's nothing wrong with that. That's why it's like I don't. Everyone has a unique gift. Everyone has a great gift, especially within our industry. So utilizing their gift and putting them in that situation where they shine is what I like to do. I go to certain nurses for certain things, like I said, and I'll go to other nurses for certain things. Even with child life specialists, while each and every one of you are great, I know that maybe this person is really good at keying in and finding out this particular information that I'm missing that I can't assess. So I'll consult to somebody, a different child life specialist, since we have multiple in our units, and just be like, hey, do you mind doing your thing and seeing what just gather your assessment and then come back to me.
Yeah.
I'm just curious to hear what you have to say. And usually it's spot on. It's like, oh yeah, that's the information I needed to help lower that barrier, lower that wall that's up right now. So hopefully build up more rapport with that patient so I can do my care.
Yeah.
Cool.
Well, I think that about wraps up our first episode. Kind of a different direction. Go ahead.
I was,
What were you gonna say?
well, I was gonna say, what with the closing direction? What direction do you see this podcast going? Like, what do we see in the future for the people that are coming back to listen?
A lot of fun.
90s get ups, you know?
Maybe some theme days
Maybe some
thrown
theme
back
days, I love
in,
that.
you know. I said, don't threaten child life with a theme. We will
Yeah.
come through.
We always win.
And they delivered.
Mhm.
They delivered. If you can't see them, let me tell you, they delivered.
I think that we all share a common goal and common dream for like the educational piece, which in my opinion the episodes are going to potentially like go in different directions, but we really want to reach like nursing staff, parents, medical providers. Like I think there's a big range of things that we could be or that we want to be doing, that we have goals and we have ideas about that we want to be doing. And I think that the overall head of that is like education and advocacy and awareness of building resiliency for our kids within the community.
Nailed it.
Cool.
I mean, couldn't have said it better myself.
Love
And I think just giving insights and awareness, you know, for all kinds of things, like special guests, you know, just different perspectives and
special guest on.
Yeah.
You never know.
I know.
Well, I love the idea of this. Again, like our industry, we need collaboration in order to move forward with providing amazing care for these kids. So thank you guys for coming up with this idea, and I'm so glad to join you guys on this
Can
journey.
we do like a 1, 2, 3 stop?
Yeah.
Right.
Yeah.
It was all a
Hands
dream,
in the
baby.
middle.
It was
Hands
all.
in the
It was all a dream.
Yeah, we can do like a 1, 2, 3.
What are we doing?
1, 2, 3.
Stop, collaborate, and listen.